Good afternoon and welcome everyone to our first Solventum webinar with Health with HIS. You might notice a couple new things. We did do our official spin in April and we're really excited that we are now Solventum. So for today, we are going to kick off our first CDI Innovation Webinar as Solventum. So thank you all for joining us. Before we get started, I'm just going to go over a couple housekeeping items. We are recording today's webinar, so if you do want to listen to this webinar again, we will have it posted to our website soon. There are a few different areas that you can look around in on the platform. This is a web-based platform. So if you are having any audio issues, check your speaker settings. And usually by doing a quick refresh, that will get rid of any glitches or errors that you might have. We do have a resources section. So if you do want to download today's presentation, that is there, as well as a couple other resources for you, as well as the certificate of attendance for today. We don't offer the CEUs, but you can utilize this certificate to reach out to other accredited associations that might accept the certificate. If you do have any questions, we encourage as many questions as you want. We'll get to as many as we can at the end. Go ahead and pop those into the Q&A box there for you. And then also at the end of the webinar, we always appreciate your feedback. So please complete that survey. We always like to know how we did. All right, so I am going to go ahead and pass this over to two really terrific speakers. They are one of our customers that we really appreciate their time today, where they're going to be talking about incorporating advanced CDI technology to help sustain program success. So without further ado, I'm going to go ahead and pass it over to our speakers to get things started.
Good afternoon, everyone. Thanks for joining us today to let us share with you our experience in using advanced CDI technology to help move our program forward. So my name is Judy Moreau. I am the Vice President of Mid-Revenue Cycle, and with me today is Andrea Eastwood. She is the Director of Clinical Documentation Integrity for Trinity Health. And before we get started on our talk, just a little bit about our organization. We are one of the largest Catholic healthcare systems in the country. We have a presence in 27 states from coast to coast, approximately 101 hospitals. That could change at any given time with a mix of acute care and critical access hospitals, and then quite a large presence in the post-acute care space. We are a faith-based organization, and so we really live into our core values of reverence, commitment to those experiencing poverty, safety, justice, stewardship, and integrity. So with that, I'll talk today about what we hope you will be able to take away from our presentation. So after hearing our talk today, you should have a greater understanding of how technology can be used to drive and maintain your CDI program performance year over year. You will be able to show ways to impact financial, quality, and clinical outcomes, and then identify how CDI prioritization and automatic impact functionality is used to set and exceed CDI targets. So anyway, our journey really began in April of 2020 in the midst of the pandemic. We, as an organization, started planning for post-pandemic recovery right as soon as the pandemic started, and formed emergency teams to look at key functions and processes across the organization in order to identify opportunities for improvement and to be leaner given the financial challenges we were facing in 2020. In calendar year 2022, our clinical documentation program was included in our Emergence Team 9 revenue cycle work effort and was challenged with improving our CDI financial benefit performance over our fiscal year 22 performance. I think anytime There, you are seeking revenue lift. CDI is always an area that people identify that could provide opportunity. One thing I will say that the pandemic also did was it spurred us on to adopt 3M CDI impact functionality. And the reason for that is we always report our CDI financial benefit on a monthly basis. And historically, we always used a year-over-year increase in CMI that was multiplied by the various payer rates to come up with our monthly financial amount. Well, when COVID came along, it completely shot that model out of the water. In April of 2020, we reported $100 million of CDI benefit when we were bleeding cash. So everyone knew that wasn't true. So with the adoption of CDI impacts, we were able to start tracking our CDI financial benefit that had less variations and not so much noise, and was really a direct reflection of the work our CDI team was doing. And I'll talk a little bit more about some of the data we started collecting, but that set us up well when we needed to set our targets for our ET9 work. So in fiscal year 22, and just so you know, our fiscal year runs from July 1st through June 30th. We were tracking for a 65.9 million CDI financial benefit. We were a little below some projections that we did. And so that really became our uplift for fiscal year 23. So we were really behind what we had projected using some of our internal data about where our program should be. So essentially, we monitored everyone's performance for the year, and we had established some targets for them. Nobody budgeted them, but we did have internal targets that we were monitoring. So because we were doing this work, it did help us. It did enable us to better set our targets. So essentially what we said was, if you hit your target in fiscal year 22, you had to maintain what you had already achieved. And if you exceeded your target in fiscal year 22, you had to maintain what you achieved. If you didn't hit your target, then you needed to hit the target that we had outlined for fiscal year 22, which we had a deficit of about $16.8 million that was left on the table. So in fiscal year 23, our total target was $82.7 million. One of the things that we did when we started this ET9 work was we looked at the tools available, looked at some of our metrics and what we needed to do to really drive performance. So we looked at our CDI impact functionality, which, if you're not aware, it does track the impact of the clinical documentation specialist queries, both from a financial and other impact perspective. And as I said, we had 2 fiscal years of CDI impact data that we use for internal benchmarking. We also looked at our CDI prioritization functionality. We did implement prioritization when it first came out, but we really hadn't looked at it in a lot of detail since our first implementation. And so we decided that we needed to reevaluate how we were setting our priority scores. And what that does is it puts at the top of the list the cases that the CDSs should review first and that probably have the most opportunity. The other thing is we had encouraged our sites to have daily CDI huddles. However, it was hit or miss, and there was no rhyme or reason about how folks conducted the huddles. So we standardized that and had the teams meet 15 to 20 minutes a day, focusing on looking at workload, staffing, and query escalations. Anything that was going to drive performance, we wanted it to be discussed at that huddle. The other thing we did do is we always said our CDSs needed a 25% query rate, but what does that mean? If you're a CDS, you really don't know what that means. So we did break that down into a number for the CDSs because we had some who had an extremely low query rate of probably 10% or less at some sites. So we did set roughly that they needed to have about 5.2 queries per day on average. That also helped us drive performance. So as I said earlier, we did leverage 2 years of CDI impact data to identify site-specific targets based on our previous year's performance. And as I said, we really kind of looked at where people landed in fiscal year 22 and then determined what their goals were for fiscal year 23. We did a complete refresh of our CDI prioritization workflow and prioritization factors to optimize our technology and drive performance. And Andrea will provide some more details about that shortly. And then we did standardize our approach to daily huddles that were going to drive performance and get us to where we needed to be to achieve our goals. So a little bit about setting our CDI targets. So we monitor a lot of data and we provide a lot of data to our facilities. So we've been capturing CDI financial impact or monitoring that for years, but as I said, we implemented CDI financial impact, the automatic functionality in June of 2020, which was fiscal year 21. We also monitor CC and MCC capture rates, and Andrea will talk about some of our results there, but we really saw some improvements there. And then we also record shifts in severity of illness, risk, and mortality. So it's not all about just the financial performance of CDI, but those other things they're impacting. And then we did look at what the average financial impact per query was, as well as some principal diagnoses and principal procedures impact. And we have been collecting this data for quite a while, so we were really able to leverage some of that to create new metrics that we looked at. So we looked at our impact query count, so how many queries did have an impact, how many queries had a financial impact, and then we looked at our impact query per total query rate, and then we looked at our financial impact per total query rate, and then the key thing that we looked at was our financial impact per reviewed case, and then our average financial impact per query. So our average financial impact per reviewed case is 5.1%, and that's a Trinity benchmark. That is the average for the organization as a whole. Some sites are lower, some sites are higher. And we really, for fiscal year 22, fine-tuned this. We have the nice thing for us is that we have an analyst who works very closely with us. And so he did a deeper analysis of the data we had collected from fiscal year 21, our first year of using impacts. And then we looked at percentages across the organization. My leader had asked that we be top decile performers. Well, CDI doesn't really work that way. There are no metrics out in the industry about what a top decile performer is. So Richard essentially took out the high-end outliers because we had some sites that had an average financial impact per reviewed case rate of 15%, some were as low as 1%. So we threw out the high and low outliers and then really looked at the average to come up with the 5.1%. And then our average financial impact per query is $5,167. And then we'll talk about what the math was to get at some of this information. So our financial impact per reviewed case The numerator is total financial impact queries divided by total cases reviewed and multiplied by 100. And then for us, as I said, and then the value of the financial impact queries is the total financial impact query dollars divided by the total financial impact query counts to give us $5,167 per financial impact query. In terms of site-specific CDI financial target, here is an example of how we do our calculations. We look at the average discharges per month by facility. We have our financial impact per reviewed case rate, which I've talked about is 5.1%, and then the value of our financial impact queries is $5,167 per query. We require, or our goal is that we will have CDSs review 90% of the cases in our CDI population, and that includes all payers for us. So essentially, we took the average discharges per month, multiplied that by 90%, and in this example, once you did that, we have 439 accounts or discharges, and then we took discharge rate and multiplied that by 5.1% to come up with, they should have 22.4. And to come out with the monthly financial benefit target, we took that 22.4 cases and multiplied it by our average financial impact dollar amount of $167 for a $115,741 monthly financial benefit target. So again, I talked about what our uplift needed for fiscal year 23 was going to be, and our overall target was $82.7 million. I am happy to report that in fiscal year 23, we exceeded our target by about $17 million. I think some of that really was owed to a couple things. It was owed to improving how prioritization worked for us, as well as really monitoring the CDSs and ensuring that they hit that 25% query rate. For fiscal year 24, we do have targets. We were asked to set those targets, and really our first goal was to maintain what we had achieved already in fiscal year 23. Typically, when you have these types of improvement initiatives, you get that big bump, and then over time, performance fades because people fall back to their old habits. Maybe you don't pay quite as much attention. So our goal really was to maintain that $98 million. We did have some sites who didn't achieve their targets in fiscal year 23. So similar to what we did the previous fiscal year 23, to set budget targets, for fiscal year 24, we said if you hit your goal or exceeded it, you needed to maintain. And for those handful of sites that didn't achieve their targets, they needed to achieve their targets. So that represented about a $2 million uplift. So our total target this year is $100.6 million for our original sites. We've added some additional sites, so it's really $102 million. And as of the end of April, we were ahead of our target. Our huddles, I've already talked a little bit about that. We felt that we really needed to standardize that work, and we felt we could leverage data from our work list to drive performance and ensure appropriate CDS coverage of cases. We are divided into 3 regions across the country, and so we decided to have regional huddles rather than each site having their own huddles. Early on, we tried that, and the managers spent all day in huddles, so that was not a very effective use of his or her time. So we do the regional huddles. We'll do some shout outs for the region or individuals on the team. We'll review the daily metrics on our work list. We'll look at staffing. Do we have enough to have coverage at each of our sites? And then we ask the CDSs if they need query escalation support from their leaders. And then we might provide some general updates as it pertains to the organization. Like right now, we're in the process of doing self-evaluation. So this is a good time to remind people to do that. And then we typically end with a reflection. Generally, we don't want the huddles to last more than 15 to 20 minutes. We want them to be quick, focused on the work that needs to happen for the day, and for the CDSs to be able to outline any barriers that they might have in being able to complete their work. We do have some site-specific huddles every few weeks to address any site-specific needs that are occurring. Again, I've talked some about this. So we look at initial reviews, subsequent reviews, discharge reviews. We look at all of that for the region and then distribute the work accordingly. We look at query actual result codes not captured in the final code set. So for those of you who may not be familiar with CDI impacts, in order for an impact to calculate, you have to have that ICD-10 code that the CDS was querying for in the final code set. If it's not there, there will be no impact. So we really want the CDSs to reach out to the coders when they don't see that code in the final code set. And then we also look at the outstanding queries for follow-up. Our query escalation occurs at all sites. Generally, we look at queries pending and focus on those greater than 7 days old. We have a process where those get escalated to executive leaders and physician advisors. And then we also have weekly meetings with people on revenue cycle from the revenue cycle participating, and we participate every couple of weeks on that and can use that opportunity to escalate any outstanding queries that we just can't seem to get answered. Because again, if the query's not answered, there's no financial impact. And with that, I'm going to let Andrea discuss our CDI prioritization refresh.
Hi, thanks, Judy. Well, I'm excited to share the prioritization refresh that we did at the beginning of our fiscal year 23. And one of the primary reasons, as Judy had noted, is we had that significant uplift target of $16.8 million to achieve, and we knew we needed to do something different. We also had not reviewed our priority functionalities since 2019. We felt we had opportunity with both our work list and our priority factors. We had heard from other Solventum clients that they were seeing improved outcomes with query rates, severity, illness, risk, and mortality shifts, CC and MCC capture, and case mix. So those were the primary drivers for us to look at this refresh. A big thing for us was moving from one large work list to 3 work lists. And this really has helped us identify where the work is in the CDI process. That one large work list had included all of our new cases, subsequent cases, discharge cases. It was pretty cumbersome. It was difficult to get a count of how many new cases we had, where the work was. So you can see that we have 3 work lists now: the initial review, subsequent review, and discharge review. Our initial review work list now functions like a new case work queue. The cases are sorted based on the highest priority score, and the teams no longer assign cases from this work list. The CDSs assign the case to themselves once they open the case and start working it. And again, the cases are based on priority score. A few of our sites were still doing it at that point in time, unit or provider assignments, but we moved strictly to reviews based on priority score at this point. And then our subsequent review work list contains cases that have initial reviews completed already. The cases on this work list are sorted based on the highest priority. It's very easy for the CDSs to get in, set the assigned to themselves, and get their list of subsequent review cases. They can also quickly navigate around their assigned to cases using multiple sort options. An example might be to get their cases to do query follow-up on. And our discharge review work list, we limited those cases on that work list to just cases with a query pending, or that had that action item where the coder had not captured our query code in their final code set, so that CDSs can make those cases a priority. Cases on our discharge list are sorted by highest priority as well. So, for a new and initial review work list, you can see that there's a count. And that count has been really helpful for us to determine how many cases the team members needed to review. You can see in the example of this one site from our test system, there were 53 cases, there were 5 CDSs working. Really easy for the team to know each team member needs to do 10 new cases for the day. In the past, some of our sites were taking as much as 30 to 45 minutes doing case assignments in the morning, and this has really streamlined the need for that. It took all of about 3 seconds for us to figure out everybody needs to do at least 10 cases for the day. We do consider it a best practice for our CDI teams to work all new cases and not limit it to those 10 to 11. But, should we have somebody call off for the day, we still know our CDSs are working those highest priority cases where they can make the most impact. And again, too, we don't want assignments made from this list. We want them to work it like it's a work queue. This is a screenshot of our columns that are on our initial review work list. And you can see that we have limited those columns to those that, help us, select a prioritized case and really expedite that review process. We eliminated things like unit and provider name, just so we didn't have any of that backsliding and maybe cherry picking cases. So that's been helpful as folks were converting to reviewing based on a work queue prioritization. Our subsequent review work list columns are here, and the column sort order that we chose were based on putting columns more front-facing that had priority score impacts. You'll see things start to turn red, and we don't typically see the columns at the end of the list in our screen view. So we wanted columns that, we could tell were impacting the priority score. If there were a follow-up due, that due date would be red. Several of our sites leverage MD Communicator, and they'll see in the pending queries that a response to the query has come in, and so they'll see that in red as well. They've also got that expander arrow over on the left-hand column where they can pop that open and get a quick view summary of anything that's contributing to that priority score, as well as get some insights into that case before they even open it. We do consider it a best practice for our CDSs to work the cases based on priority order, but we want them to manage their subsequent review list in totality. So we want them to scroll through that list, see if any cases, even though they might have low priority scores, might need a review. And so we do have them take a look at their whole list. Our discharge review work list columns are identical to the subsequent review, with the exception that we added the last coder and the DRG reason code at the very end of the work list, so that those are viewable to the CDS to help them expedite following up with the coder, especially for those action items where the coder might not have captured our code in their final code set. So we can get that reconciliation discussion via email started and prioritized. And again, our cases are limited to those with a query and that one action item. Our CDSs do follow up on their own pending queries at discharge. For cases that are on the initial review work list, these are the priority factors that are impacting those. And you can see the point scores that we assigned. Our goal was to surface cases that had the greatest opportunity at the top of the list. And again, our CDSs work the cases like a work queue. You can see for new documents for other 1 and other 2, we chose ED provider note and consultation. And those have really helped us with ensuring documentation that really helps with that first review is there for the CDS. Our subsequent review priority factors are here and with all the point scores. So you'll have these for your reference. When we did our refresh, it was the first time that we started leveraging the focus DRG. And on the next slide, I'll review the detail of our focus DRGs. But another priority factor that's been really helpful is that one titled New Auto-Suggested DRG. And that's where a new DRG by the system is calculated that's different from the CDS's working DRG, and it's going to add 65 points to the case. We feel this is an important thing for the CDS's to have surfaced to them because there might be a reason the system is suggesting a new auto-suggested DRG, and maybe we need to take a second look at it from a CDI perspective. There might be a documentation or query opportunity. And when you go back and look at this column sort order for our subsequent and discharge review list, you'll see that we position the CDS's working DRG column right next to the auto-suggested DRG column. So when that priority score is triggered, adding those 65 points, they can do a quick look right from their work list of what those 2 different DRGs are. As I mentioned, this was our first time leveraging focus DRGs, and we decided to break them into 2 categories, surgical and medical. And you can see we've got significant procedures categories, and for us, we included, some of our challenges. We wanted to include those significant procedures such as transplants and craniotomies, some other procedures there as well. But for our smaller sites that, they don't provide that service, these aren't, adding additional cases to their work list because they just don't exist for them. So it's not adding any additional noise. And you'll see too, we've included some problematic procedures, and those are those non-specific procedures we really need to take a look at. For our focus medical DRGs, you'll see under the problematic DRGs, our sepsis ones, they're a problem for all of us. You'll see that we have included DRGs in our focus list that are MCCs. And we did that specifically because we know for some of these problematic and significant procedure DRGs, the payers, if there is only one MCC, really like to take that one away from us. So we want our CDSs to ensure that that MCC is appropriately assigned and that it is well documented throughout the record. In addition to that, if there are any potential additional MCCs, we want to take advantage of not having that case move down the list in priority and have the CDSs, query for those additional MCCs if appropriate. And we kind of consider that audit proofing the record. You'll also see under the medical DRGs a grouping. We're calling them non-specific DRGs. Those are those problematic DRGs you're all familiar with as well, such as TIA, headache, chest pain, syncope, medical back. So, we know all those cases definitely could benefit from CDI review, and those surface, all of our focus DRGs surface 104 points in addition to the other priority score points for cases. For priority factors influencing cases on our discharge review work list, again, only 2 types of cases are hitting that list, and those are with queries pending and the action item where the coder didn't capture our queried code. And you can see for that action item, it will surface 151 points to really move those up on the CDS's attention and priority list when they get in and sort on their discharges so that they can address those. In a lot of cases, we get that reconciliation email started with the coders, and we're able to, and in some cases, the coder will make a change to their final code set even before that final bill has dropped. Now here's the exciting part. We get to share the outcomes that we've achieved. In fiscal year 23, we saw our CC capture rate increase by 80.4% over the previous fiscal year. We really attribute that significant increase to the changes that we made within CDI prioritization and within our work list. You know, the work list changes allowed us to look at where the work was in the process, how many new cases we had, subsequent reviews we had, really do that workload balancing to ensure that we were using our CDSs and they were focused on the work that needed to be done. And then, as Judy mentioned, those query escalations above the escalations to our physician advisors, where these escalations go weekly or biweekly to our executive and physician leaders, has been extremely helpful. For that same time period, we saw our MCC capture rate increase by 41.9%, again, attributing that increase to those same things that I just mentioned on the previous slide. As Judy mentioned, our financial benefit for fiscal year 23 not only met that significant uplift, we exceeded it by about $17 million. So we were really pleased with the results as it related to the financial impact as well. And we're really happy to share that we're seeing that sustained performance in fiscal year 24. We're still seeing a slight increase. It's up, 29.3% over fiscal year 23. And our MCC capture is increased 12.8% over last year. Our financial benefit target, and Judy shared, we're targeting about $100 million across our 47 CDI programs, and we are still ahead of where we would have anticipated to be fiscal year to date for our financial benefit targets. And I think through April, we are a little more than 10 million ahead of our fiscal year to date target. One of the things that we added is some proactive monitoring of our financial impact. We calculate it on a weekly basis now. It allows us to look into the data a little deeper, develop some action plans during the month. So there's nothing worse than getting to the end of the month, running our month-end data and finding out we missed our target. So we're really leveraging the system and the reporting capabilities to see where we are throughout the month and make those changes while we still have time to impact our targets and our outcomes. Some of the steps that we took after prioritization is that we now are on track to review our priority factors in June of every year. We looked at them last year. We're looking at them again this year, making minor tweaks to them and maybe prioritizing DRGs differently based on some current experiences and challenges that we're having. We're reviewing the functionality in the system and what's available, what's come out. Throughout this past year, we want to make sure that we didn't miss implementing anything. We pretty much try to implement things as they are released, but we do this once a year check on the functionality as well. Another proactive measure that we implemented about 7 months ago was we pushed all of our focus DRGs to a special work list called a second level review work list. This work list can be worked independently. It's worked by our supervisors. It doesn't interfere with the CDSs working their subsequent review cases. And the supervisors serve as a second set of eyes. And as they see maybe a query opportunity or a documentation opportunity, or they might have a question about a case, they route the case to the CDS real time while the patient's in-house. So this has been a great way for us to achieve some additional improvements. And we are continuing to build on that impact monitoring and tracking those impacts beyond the final financial impacts that we're making. Just as just a sample of those other impacts, looking at tracking our impacts on principal diagnosis, principal procedure, clinical validity queries, our shifts in severity and risk of mortality. We're looking at now including in our benefit reporting, capturing of queries that impact quality measures and Alex Hauser, present on a mission. Again, we want to continue to build on that, showcasing the great work that our CDSs are doing beyond that financial impact. To incorporate the advanced technology and help your programs sustain the success. These are some of the key things we think need to happen, and really inventorying the tools and resources and functionality available within the system and to you, and optimizing that functionality. Talk to your Solventum representatives and others that utilize the software to see how they're using it. And we really think this proactive monitoring of performance with our queries and what's outstanding on a weekly basis, escalating those to executive and physician leaders, tracking the financial benefit has really helped us stay in touch and not be surprised at the end of the month. The daily huddles have been a great way to connect with our CDSs and the valuable work that they're doing. We conduct periodic reviews of the functionality, and implementing the functionality is only one step of the process of making sure that you're optimizing all of the functionality. You really need to link that functionality to how our CDSs are using it in their daily processes. Leverage executive and physician leaders when you get that opportunity. Can't say enough about the support that we've received. And then be creative in your approach. And I really want to give a shout out to our frontline CDSs and our CDI leaders, because they've been the ones that have been embracing the technology, really making sure that it's utilized in their daily processes so that we can achieve these great outcomes. So we are at the point in the presentation where Judy and I can answer any questions.
Great. Thank you both. There is so much information here, and it was so well organized and just really a great presentation. So we do have some questions. We'll get to as many as we can. So let's start at the beginning. Is the impact functionality the same as Engage One function? Is Trinity using Engage One?
We are at 360 Encompass. No, we do not have Engage One.
Next question, do you include any negative dollar loss in your query impact financials?
So we actually removed the negative impacts. We felt that, it's difficult to explain to, our financial leaders and executive leaders what the negative dollars represent. We feel that that is revenue preservation. So we do only report the positive dollars in those calculations.
How do you calculate financial impact per query when the system calculates it at the visit level?
Yeah, so we take those individual visits, and those are totaled up in the impact report calculation for the site. And then we look at how many financially impactful queries we had. And that slide that Judy presented will show the exact calculation of how we do those totaling. And happy to meet with someone afterwards to explain that, but it's definitely an average of things. So taking those individual cases and averaging them.
What does your leadership structure look like for the CDI department? How many initial reviews do you expect a CDS to review each day? So it's a two-part question.
Yeah, so each region has a CDI manager, and depending on the size of the region, they'll have 2 to 3 supervisors. Only one region has 3 supervisors, the other has 2. The larger region that has 3 supervisors has 2 coordinators, and the other 2 regions have 1 coordinator each. And then what was the second part of the question?
How many initial reviews do you expect a CDS to review each day?
Yeah, so we target a total of 21 reviews total, and we really look for that mix of new and subsequent reviews to be a balance. And we know there's some factors with, admissions. We might only have enough for the team to do 8 admissions a day. So when that happens, we're expecting the balance of 21 total reviews to be made up with subsequent reviews.
Awesome. This is another kind of two-part question. With so many queries being sent, are providers complaining of query fatigue, or have you gotten a good response? And secondly, do you have, go ahead. You answer that first, and then I'll ask the second part.
Yeah, we've gotten great responses. We've not really had any complaints about query fatigue. A lot of our sites now are leveraging MD Communicator. It allows the one-click response to the query, generates the query document response for them. So a lot of the query responsibility is streamlined and easy for the provider. For those sites that aren't yet leveraging that tool, we haven't had any concerns raised from them.
Do you have an escalation process then, or you haven't needed to really do anything?
Yeah, we do. We do escalations normally, like either, with a physician champion if the site is, most of our sites have a champion. Some sites don't. In some cases, the CMO might serve as the champion. We'll escalate to those individuals. Some want those query escalations on what we call on the fly. So as they, after 24 to 48 hours, they want to know the doc hasn't answered the query. So we let them know on the cadence that they want to know. But this additional escalation that we shared in the presentation is we're looking at queries that have been outstanding for a week and letting executive and physician leaders know. They are really interested in understanding who's holding up the queries. We include coder queries as well. So, those are potentially holding up discharge not final coded. So that's like an extra layer of escalation. And it kind of helped where we had some sites stall out with query escalations at the physician advisor level.
Are your queries part of the permanent medical record?
They are, yes.
Do you have the CDI encoders review their negative impact queries and correct?
Yeah, the CDSs can see their negative impacts as they're closing out their query. As part of our process of looking at queries as well and having a layer of validation, all the supervisors review every single query that's sent and that has an impact tag to it to ensure that we're calculating that impact accurately. So we do that, we call it account validation level of second level review.
Can you speak a bit more to your DRG reconciliation process? Are you only reviewing those cases with a DRG reason that hit the DC list for your specified reasons, or do you have a separate reconciliation process?
Yeah, so our reconciliation process has been streamlined significantly over the last couple years. A CDS might initiate the reconciliation process with a coder, based on that action item where the coder didn't capture or queried code in their final code set. So, we get that action item alert and we start the reconciliation. In some cases, the coder will initiate it. And the coder would start a reconciliation when they've assigned a DRG that's different from ours and they don't know why. If it's due to subsequent documentation or a coding guideline, we aren't having the coder stop their process of final billing, final coding, and reconcile that case with the CDS. We look at those from more a reporting perspective, and then we look at those when we have our CDI encoding collaborative meetings.
Do you key in on cases with no CC/MCC even when they are not prioritizing?
Yeah, so that's the great thing about the sorting capabilities within the work list. You can, and that's where the supervisors are, leveraging that sorting functionality to maybe sort off of cases that are a medical case without a CC or an MCC, and they'll see what's there. They're going to be able to see that the length of stay is exceeded. We still don't have a CC or an MCC. They might see the fact that maybe a follow-up's a couple days past due. So that's how they're randomly, somewhat targetedly picking cases from that second level review work list to, maybe ask the CDS to review that case or see if there's a missed query opportunity. So we're definitely leveraging the work list and the ability to sort within the work list to target cases.
And can you kind of talk about, one of the questions is, what was the name of the tool that you're using? Can you go into a little bit detail how you are utilizing the tool?
Yeah, is it the MD Communicator question?
Yes. Yep.
Yeah, so for MD Communicator is, I believe it's a function of EMD, but it just is a query routing tool. For us, it sits on top of the Epic EMR, and when a provider enters Epic, they'll get a pop-up message that they have outstanding queries, and that pop-up is the MD Communicator letting them know. They can choose to answer queries at that point and open their list of queries from that pop-up. They've got to get right into patient care. It's not going to impede them. They'll also get that pop-up that shows when they enter the case of a patient that has an outstanding query. And again, if they don't address those queries at that point, that pop-up, it'll minimize down into their taskbar, so they can click on that, that icon for MD Communicator and pop up their query list at any point in time. They don't have to go out to an in-basket or a message center to get queries. When they open their list of queries, they will see in some cases a lot of our queries have been formatted in multiple choice format, and the multiple choice options are there. They can click with one click, and that generates their query response document. So it really has expedited and made query responses easy for the providers. In a lot of cases where we have implemented this, our sites that have it in place are seeing query responses in under 24 hours.
I'm going to kind of combine these next two. So it's kind of asking about performance for the CDSs and ensuring their accuracy. So how do you monitor the CDS's performance to ensure that? And then secondly, how do you keep the CDSs from cherry picking their cases with the self-assessment?
Yeah, so the supervisors we can all see the initial review work list. We can see if cases are aging that have a higher priority score, and you can see the priority score history. So some of it is just a little bit of monitoring and being in the work list and seeing what's still on there. As we're prepping for the workload balancing discussion from a management perspective, we're in the work list, so we'll see those things. Can you help me with the second question?
Yeah, it was just around how do you keep the CDSs from cherry picking their cases with the Yep.
Yeah, so on the initial review work list, when you go back and look at those slides, you'll see that there's probably only about seven or eight columns. So we don't present to them all the columns. It's basically they all take the top case on the list. If they start cherry picking or trying to assign cases, it doesn't reserve the case for them. So the next person taking the top case will get it. So, it's been a little bit of working with the teams and ensuring they know how this works like a work queue. But then we limited the columns so that, they can't pre-select cases and try to assign them to themselves. And, we'll see if they're trying to assign them to themselves from that initial review work list. I would say after probably about the first 2 weeks of the prioritization refresh, the CDSs were great. We didn't see any of that activity.
As far as the kind of getting the leadership buy-in, we all know what financial impact means, but how have you been able to relay that concept to your C-suite in regards to whether it's true net revenue?
Yeah, so we, and Judy might want to add to this, when, we had monitored the functionality and had it in place and actually generated the financial impact reports for a year before we shared it with others, and including our executive leaders. And we have a revenue team at the corporate level that definitely looks in detail at this kind of data and vetted it with them. Again, making sure that we, worked with our analysts, removed low and high outliers. They actually felt this was a much better way to display the financial impact our CDI teams are making. than the case mix, because there's so many variabilities with case mix. The types of patients that are coming in, seasonality, and as Judy said, throw in a pandemic, and our whole case mix monitoring was totally invalid. So the financial leaders at the system level actually like this methodology better because it is a truer reflection of the work CDI is doing. Judy, I don't know if you had anything else to add.
I can add that our reimbursement team has a tool where they monitor case mix index almost by service line, and they can kind of tell, how we're tracking. And typically, case mix index has increased in areas where we really have an impact. Where we sometimes get questioned is overall case mix may have fallen, but case mix was never going to be as high as it was during COVID. But everybody believes that this is a more accurate way to report the benefit of CDI, and it should translate into actual dollars. Where we sort of fall a little bit short is we don't have a good way to tie, did we query for these diagnoses, we coded these diagnoses based on the query, and then the payer came along and denied it. That's sort of something we're still working towards.
We still have a couple more questions. I know I'm going to try to at least get to this one, and then if we have time for one more, we will. But do you reconcile your denials against your CDI queries?
No.
Yeah, that's what Judy was we're challenged with that. We don't have
good information about that. And we really, like I say, we still, as an organization, still haven't come up with a good way to really get it down to the specific diagnosis that it's not so much, I would say, cause the denial, but cause more the DRG downgrade. So essentially, they take away your CC and MCC, and then you get a downgraded DRG. In some instances, they might ask for the record and they'll completely change the DRG, but typically what we see are DRG downgrades. But no, we're not reconciling denials at this stage of the game.
Okay, let's try for one more. I know you're not using Engage One, but are you using evidence sheets?
No, we don't have the evidence sheet. It's not part of the MD communicator functionality. I've seen those. Those are really nice. But no, we're not using those.
All right. Well, let's go ahead and since we are just about at time, is there anything else that you would like to kind of add for final thoughts before I wrap up for today?
No, we just really appreciate sharing the work that our teams have done with everyone. So thank you.
Yes,
yeah, absolutely. We really, really appreciate this. This is such a great presentation. And obviously, with as many questions as we had, you can tell that the audience was really engaged. So we really appreciate it. Again, we are recording today's webinar. So if you do want to listen into it again, it will be posted on our website here in the next couple weeks. And pretty soon, if you haven't gotten any information on it yet, check your emails. And for next week, we are going to be opening up registration for our Client Experience Summit. That is for our customers, and would love for you to join us in Dallas. We're excited to be there this year. So keep an eye out for that. Again, that is for our customers. It is a complimentary registration and includes all your food and beverages. You just got to get there. So we hope you can join us there. And then we look forward to seeing you next time for our next CDI Innovation Webinar. So thank you again to our speakers. If you do, before you close out of the browser, make sure you download the presentation and any of the other resources before you close and complete that survey. So again, thank you very much for your time today, and we look forward to the next time. Thank you so much.